My name's Jessica Rice. I've been here, I'm a MS neurologist here at the MS Center. I've been here about 2 years now. Before that, I was at OHSU for a while, so I didn't go far. And today I'll be talking about, this is our MS 101 presentation. We're trying to give it more often now. I shouldn't say post-COVID, but trying to give it more now than we were in the last couple years. It's intended, this is not an exhaustive everything you could ever possibly want to know about multiple sclerosis. It's intended as an introduction. And of course, if you yourself or someone you know has multiple sclerosis, any specific questions, I'm sure your MS neurologist could answer as well. This is meant sort of as a overview. So let's hope it works. Okay, so we'll talk about just what is MS, what are some of the symptoms, what are the different types or courses or subtypes of MS. We'll talk about how we make the diagnosis, our current approach to treatment, not only with disease-modifying therapy, but a little bit about symptoms as well, a little bit about wellness, and then what's on the horizon. I know some in these lecture series, there's separate talks given about new advances in multiple sclerosis and other talks focusing more on wellness. So these last two bullet points I'll just talk briefly about, and I think future presentations / past presentations have touched more on those. So just what is multiple sclerosis? It's an autoimmune condition. It's a lifelong disease. It can affect your brain, your spinal cord, or the optic nerves. Most patients, I try to be optimistic here, actually these days do not eventually become severely disabled. I'll get into the details about treatments and the nitty-gritty about that. Said it's an autoimmune disorder, and essentially it's where your immune system has decided incorrectly that this myelin, this oh good, you can see it. This myelin is some protein covering that protects the nerves, and your immune system has again decided that it is something that it needs to attack. It looks like something your immune system needs to attack and deal with, and unfortunately that leads to your immune system attacking your myelin sheath, which can not only damage the myelin and slow the conduction of the information down the nerve, but damage the nerve tissue, the nerve fiber itself, which can lead this damage to the myelin. Essentially forms the scar tissue. That's the sclerosis part of multiple sclerosis, the scars that we can continue, unfortunately, to see on MRIs and leads to symptoms. I will dive into the specifics of that. So the immune system is the main driver of the development of multiple sclerosis. That's what immunopathogenesis means, is it's sort of the immune system's role in creating and starting multiple sclerosis. I won't get too into the science of it, but essentially out here, this is kind of your bloodstream, and this is this is representing a B cell activating a T cell. There's a bunch of different types of immune cells. That this is B cell telling the T cell that, hey, you need to go attack the myelin. And so this T cell comes by, this is representing the blood-brain barrier. So this immune cell kind of comes on through, gets reactivated here, and it leads to that attack of the myelin, leading to a lot of, again, inflammation and damage and eventually scarring. So it's those basic, there's a lot of other stuff going on as well, but that's the basic issue. How prevalent, how common is multiple sclerosis? For many years, we cited this 400,000 number. This is in the United States specifically, but a new study came out in 2019. It looked at cases in the United States up to 2017, and that estimate was over 900,000. So almost twice the number of patients that we thought there were. Twice as prevalent as we thought. So this was a good update for that number. You can see this increase in numbers over the years. What we think is happening here, not necessarily that MS is happening more. We think we're recognizing it more. We're diagnosing it faster, easier. We're just recognizing it more, basically. Who develops multiple sclerosis? The peak age is 20s to 30s, but anywhere 20s, 30s, 40s, 50s is common. It can start as early as teens. A few kids rarely can develop MS, but it's possible. Right now, there is a female predominance, about 3 to 1, but Still unclear exactly why that happens. Current statistics show that Caucasians are more likely to have multiple sclerosis. I think it's unclear if this is, you can see the bullet point below this is advertising the National African Americans with MS Registry. This is because historically, African Americans have been underrepresented in research. So we're trying to figure out, are these current statistics accurate or not, or is it just an underrepresentation in the research? There is a clear geographic distribution, though, where there seems to be more cases of MS in kind of northern latitudes, whether that's here in the United States or in Europe as well. And I think another picture, yep, there, where you can see this. I will say these colors, these numbers are based on that older 400,000 prevalence in the United States data, but you kind of get you can still see what we're getting at here, where it's much more common in the United States, Canada, Northern Europe. Not sure what's going on with France there. Lucky French people, I guess. And just less common in more southern latitudes, basically. We think that has to do with the role of vitamin D, and I'll come back to that. So what actually causes MS? It's the oversimplification is a mix of genes and environment. There is a genetic predisposition in combination with potential infectious agents, specifically viruses. One virus in particular has we've kind of honed in on, and other environmental factors that, again, comes back down to this vitamin D question. There are a lot of other potential triggers that I'd say are being researched right now, but don't quite have enough. Things like gut microbiome and vascular risk factors, all of these things are being looked at, but are still very much in kind of our earliest understanding of these conditions. So I think it's probably not even as simple as these three things. It's a very, very complex disease. And then I always tell my patients, just the final arrow should just be bad luck, is just bad luck is associated with getting MS. So with the genetics, there is no direct gene that you inherit that causes multiple sclerosis. This International MS Genetics Consortium identified over 200 different genes that have been associated with MS. And so that's a lot, obviously. So again, there's not clearly any one gene. All of these over 200 different genes, all of them were genes that code basically your immune system. So the way I think of it is you inherit not getting MS, but you inherit an immune system that might be more prone to attacking itself. This number, this 1 in 300 number of developing MS, this is specifically for overall genetic risk, not the kind of whole population risk is a little closer to 1 in 1,000 or 1 in 700 here in Oregon. So this risk increases, like you saw. Greater risk if you have a parent with MS or a sibling with MS. So again, no single gene. It's not guaranteed to be passed down from parent to child, but might be a higher risk if a family member has MS or has other autoimmune conditions. Then the other cause, the viral causes, in particular Epstein-Barr virus, especially in the last year, we really kind of honed in on this virus in particular. There was a study that came out, say about a year ago now, probably a little over a year. We've kind of suspected Epstein-Barr for a long time, but this was a study that finally had the numbers to really show this association. So antibodies to the Epstein-Barr virus were seen in 99% of people with MS in the study, as opposed to 90 to 95% of healthy controls. Now, that's still a really high number. Epstein-Barr virus is still really, really common amongst general population. So that alone is clearly not the cause of MS, or a lot of other people would have MS. So there's something else going on, but it's clearly it's clearly associated. There's some risk factor here. So overall, the study, because of numbers and statistics, the way it came out is essentially of 20 times more like the risk, 20 times more likely to develop MS if you've had infectious mononucleosis, which is one of the clinical syndromes that can be caused by Epstein-Barr virus. Epstein-Barr virus can also cause just colds, especially in young children. So even if you don't recall having mono, it's possible, a person with MS might have had Epstein-Barr virus as a one of the many childhood cold upper respiratory illnesses that happen. A study also showed that there was an even higher risk associated with smokers. I'd say a lot of studies are being conducted, designed right now as we speak to further explore what's going on with Epstein-Barr virus. Vitamin D, I mentioned this already in kind of the geographic distribution. There's a lot of studies to show that there can be a protective effect of having normal vitamin D. Some studies are mixed. Once you have MS, vitamin D is helpful. We still recommend it to patients because I personally feel that there's enough studies that show it's associated with more mild course that sort of it's a nice to have. You know, it alone is not sufficient to treat your MS, but it's sort of a, well, it can't hurt type of thing. Because vitamin D is fat soluble, which means some vitamins, if like the B vitamins, vitamin C, if you took too much of it, you would probably just pee it out. But vitamin D can get stored in the fat, so it is possible to have too much vitamin D. So that's why we work closely with patients to make sure your levels are okay. Persistently high levels of vitamin D doesn't happen often, but when it does, can be associated with kidney stones because vitamin D helps you absorb calcium. Calcium could lead to kidney stones. So, so we encourage vitamin D, but we monitor it. So work with your doctor on taking vitamin D. So there are a lot of different symptoms that can happen. They're variable. They can depend on where lesions occur, how much inflammation there is. It would depend on if there's lesions in the spinal cord versus the brain versus the eye. Very broadly speaking, more lesions, and by that I mean the scar, the sclerosis, is associated with more serious or more disabling symptoms. Some symptoms you can recover from symptoms of MS. Some come and go even after you've recovered. It's unfortunately very highly variable. And for a relapse, that is where there's new neurologic symptoms you've never had before. We expect those to last at least 24 hours, but usually end up lasting days to weeks. And there's a long list. This is not an exhaustive list of symptoms that can happen, but include, broadly speaking, vision problems, sensory symptoms, pain, weakness, muscle spasms, walking problems, bladder problems, problems with memory, fatigue, depression. This is very broad, very, very, very broad to say the least. And again, where we would want you to work closely with your doctor. And so this is, can be tough because there can be so many symptoms associated. It's sometimes hard to know. Yes, yeah.
Insomnia.
Yeah, and a lot of different things can contribute to insomnia. Some related to MS, some not. So absolutely, I absolutely see patients with MS have insomnia. It's very, very complex. All the different symptoms that can be associated with it, which is challenging. So the different courses, or maybe the other phrase for it is subtypes of MS. Far and away, the most common subtype is relapsing remitting MS. Over 90%, I kind of feel like sometimes it feels more like 95% of people are diagnosed or start off with relapsing remitting MS. And there can be, you can see here, these arrows represent kind of new lesions on the MRI. So for example, say with this right here, you say you have an optic neuritis that affects your vision, just as an example. You might have, hopefully my comes back. All right. You have some symptoms. They last for a while. The symptoms improve. You're back to baseline. And then this is maybe where there's an asymptomatic, a new lesion on the MRI that you don't feel. And then maybe, come back. Okay. Hopefully you can still see my mouse a little bit. And then maybe here you have new leg weakness, for example, or weakness of your legs. That is happening. It lasts for a while, but then you don't recover all of the way. Maybe you're left with some foot drop, or maybe that leg is just always a little bit weak. And then you can kind of see how you can start to accumulate problems with more and more and more relapses. I should say this is the course of untreated relapsing remitting MS, I should emphasize. I'll get to it when we talk about the medicines, but our goal with using the disease-modifying therapies is just after this first attack, so we can, is often how we diagnose MS, is after the first attack. We can make sure that none of these happen, is sort of that's our goal. We strive for that. No medicine is perfect, but that's what we hope. So sometimes people Sometimes these relapses can be very close together. Sometimes they can be many, many years apart. Sometimes you recover all the way. Sometimes you don't recover all of the way. Sometimes people recover only a little bit. It's, again, variable, unfortunately. But this is far and away the most common type. Secondary progressive MS is something that happens after relapsing remitting. It's comes second, so that's why it's named secondary progressive. So no one starts off secondary progressive MS. So you can see in the picture, the gray is relapsing remitting MS. So say you've kind of moved on from that. This is associated with what we call progression is symptoms that just, it's not a clear up and down attack of symptoms. There just might be things that just slowly get worse over time. There's an overlap period where you could be slowly getting worse and have relapses. That is what we refer to as an active secondary progressive MS. Sometimes it's hard to tell when you're in this phase. A lot of times only in retrospect can we look back in time and say, oh, okay, maybe this is what was going on. In the moment, it can be really hard to tell where you're at. There's no test to determine if you're secondary progressive or not. It's sort of something that we just have to, again, decide based on history in your course and all of that. One statistic is this is older and from the 90s, but 50% of patients, again, I want to emphasize with untreated relapsing remitting MS, will progress to the secondary progressive phase within just 10 years. It's also would not be unusual for it to take, 15, 20, 30 years. More recent studies, since we've been treating folks, we've found that it's happening less. Patients are either not going on to develop secondary progressive MS at all, or it's happening later and later and later. So we are making a difference with our medicines to either, again, push this out, prevent this worsening. And then there's primary progressive. This is the other subtype or course of MS that you can start off with. It's much more rare. And I know the statistics say 10%. I feel like it's closer to 5. At least that's how rare it feels. And this is where there's no clear relapses. I know this picture makes it look kind of confusing, but strictly speaking, no clear relapses. It's just symptoms start and they just slowly get worse over time. And it's a frustrating subtype to have. I know there's a very busy slide, so I'll just, what I'm trying to get across here is, so this axis is age over time, increasing disability over here, and each of these blue lines is representing a relapse that you might see on the MRI. This dotted line is clinical threshold, so maybe this is this clinically isolated syndrome. What that's referring to is your first clinical attack that you felt. And that's why some people, when they're first diagnosed and they first get an MRI, we see lesions on the, we see multiple lesions already. And that's sort of this pre-symptomatic disease state. And then it kind of goes into this relapsing remitting phase where, again, this is an untreated course, by the way, where there might be multiple relapses. And then as relapses kind of fizzle out over time, this is where kind of more and more progression happens. And then you can see this line for primary progressive. It starts right here because, again, it doesn't include a lot of the ups and downs. It just slowly gets worse. So the other statistic that we think it's, again, this is from the 90s and is not true now, but 15 years after MS onset, 50% of patients were basically disabled to the point where they needed a cane. Again, this was prior to development of any of our medicines, I'd like to emphasize, but can show how the expected course of MS can be. Now, 50%, that's not everyone. Some people do have a much more mild course, have a much more benign course, but 50% is still really high. We want to prevent as many people as possible from needing a cane, from needing, we want to keep people walking and functioning as well as possible for as long as possible. Another statistic is if you have 40% of patients, if they have a really severe attack that, affects their walking or makes them unable to walk or move, 40% of those, just under half, don't always recover all of the way. So again, really important for us to why we are so highly motivated to prevent relapses before they happen, basically. So we don't want this. Like this picture of MS iceberg, what we see, what you might see or feel is relapses that you tell us about, or even unreported relapses that might not happen. Below the surface is where there might be new MRI lesions you don't feel. There, what this is talking about, gray and white matter lesions not detected by MRI. What that's referring to is as good as our MRIs are. We know just from doing, sadly, autopsies later on that there is even more damage than we're just not picking up well on the MRIs, and that's just a current limitation of our technology. And then just brain atrophy is happening as well. Again, this is untreated MS, but so there's a lot happening even if you're not feeling it per se. So yeah. So how do we make the diagnosis? Of course, first we will take a history that is talking about current symptoms, previous symptoms, family history, very important. I'll do a physical exam, a neurologic exam, blood tests. We might do blood tests to rule out other conditions that can mimic multiple sclerosis, but there's no specific blood test that can, sadly, unfortunately, that would make my life a lot easier. If there was just a simple blood test that could diagnose MS, that would be great. Spinal fluid can be really, really helpful. As our MRIs have gotten better over the years, it's not required anymore. It can be helpful, but it's not obligatory anymore, which is good news for most people who don't want to get a spinal tap. But sometimes we will still do it because it can be helpful additional information if there's any concern or question about the diagnosis. So the MRI is a big, big, big part of the diagnosis. It shows areas of damage. You might have heard me use the word lesion already. An older word for it was plaques. You might read that in MRI reports. We try not to use it as much because the word plaque has kind of been associated more with Alzheimer's and things like that. And so it can get confusing. So we're trying to use the word lesions more than plaques, but it's still essentially they're interchangeable. And then on the MRI, it's a bunch of filters basically that give us a bunch of different information. Two of the most common filters that I look at, one could be this T1 weighted. If you ever read an MRI report, you might recognize some of these words. This is where the contrast is given, and this on this filter with the contrast, it can light up if there are new lesions, specifically new inflammation that's happening. Definitely within the last month. It can be as long as the last 2, possibly as long as even 3 months, but definitely in the last month or 2, it lets us see if there's any inflammation going on like right now. The T2 scans would let me see any old or new, any previous lesions basically. So they'll show any of those previous older inactive lesions. So here's example of what we're looking at. This one over here. Sometimes it's just one. This is just from the internet. There's no particular patient in particular, but what we're seeing with this, you can see a couple areas here that look bright, and these are this poor person's relapses going on right now. So hopefully this person got treated with some medicine. This is what the other filter, this T2 picture looks like, and so all of the white spots here that I'm showing you are all MS lesions, some old, probably some old. And this is just another view still with the T2. This is sort of our best pick. This is very common. MS loves to touch this black filled space here is the ventricle. It's a fluid filled space in the brain. And MS is very common to kind of have these finger-like projections off of that space. It can also affect, this is the brain stem here, and this is the cerebellum, the back of your head. So you can kind of see these white blobs here. We would say that there are lesions here.
What it do to you if they're in the cerebellum like that? What happens?
Cerebellum specifically tends to be more balance, but yeah, it can vary. And then finally the spine. It's a little subtle here, and that kind of reflects real life. Sometimes it's hard to image the spinal cord. It's a real small, compact area. But this dark line here is the spinal cord. The white on either side is the spinal fluid. We're kind of looking at the person from the side, and these are all the bones here and kind of the discs in between. The spinal cord should be sort of a single color of this dark gray, but you can kind of see a little white spot there, and it's kind of fuzzy, but some up here, and those would represent MS lesions in the spinal cord. think it's important to note that not everything that shows up as white is MS. On the MRI, there's age-related changes. Every decade that we live, we all accumulate more and more white spots. How do we differentiate this from the MS lesions? As part of our diagnostic criteria, the spots have to be in very specific locations, have a certain size and shape to them as well. Migraines can cause white spots. Other risk factors are high blood pressure, diabetes, high cholesterol. All of these things can cause white spots. Smoking, post-traumatic lesions, that's referring to traumatic brain injury specifically. You could be born with these spots if there was any kind of perinatal injury. And if you've had radiation, that'll leave white spots as well. And so these are all very different things, but our MRIs are just black, white, or gray. And so they all just show up as white spots.
Had CAT scans, you get white spots and not really safe.
Yeah, this the radiation is referring to like cancer levels of radiation. Yeah, nothing that you would get from a CT
Not from
scan.
microwave.
No, not from microwave. It would have to be really high levels that they give you if you've are unfortunate to have had some kind of head or neck cancer, for example. Treatment. Time for specific relapses that are associated with those new enhancing lesions on the MRI, we might give some steroids. Most commonly is IV steroids, 3 or 5 days, depending on kind of how severe it is, and depend on maybe that individual's how well they tolerate steroids. Steroids can have a lot of side effects, and so not everyone wants all 5 days. And then symptoms of relapse. I kind of mentioned some symptoms already, but it could be a lot of different things. You can have spasticity, weakness, sensory symptoms, bladder dysfunction, and optic neuritis, double vision, balance. So admittedly, usually not subtle things are associated with relapse. For the sake of time, I think previously we'd had in here different treatments that you could do for each of these conditions, but I want to make sure we get through everything. So maybe afterwards we can talk about how we go about treating each of these specific symptoms. But for the sake of time, I won't dive into it because probably each one of these on its own is probably an hour talk about how we can help and what we try to do. So want to make sure we talk about the disease modifying therapy. It's like to be extra clear from the beginning that there are things that disease modifying therapies can do and things they can't do. The goals of using a disease modifying therapy or a DMT is to reduce the risk of relapses, reduce the risk of new lesions on the MRI, and overall delay that progression, that secondary progression, and ultimately prevent disability, prevent walking problems, prevent cognitive, prevent as many problems as we can down the road. We have many studies have shown that starting a therapy, especially for relapsing remitting MS, as early as possible is really associated with better improved outcomes. What it doesn't do is we currently do not have any medicine that can repair the lesions or remove the lesions, and any symptoms from a previous with relapsing remitting MS, a symptom of a relapse can improve. That's the remission part. That can happen regardless of the disease modifying therapy. So if you have any residual symptoms that did not improve after a relapse, disease modifying therapy would not necessarily help those symptoms. But if we can prevent another relapse that can add to that list of symptoms you're experiencing, that's still valuable. So I like to be really clear with folks that I kind of think of it as a preventative measure, essentially. Once something has happened, that lesion is there, those symptoms are there, but it's really important that we prevent any other attacks or any other symptoms as much as possible. So this is sort of getting at this. Yeah.
Can it heal up if you have lesion like my leg?
Yeah, absolutely.
Doesn't it heal kind of?
Absolutely, and that's part of the, that's in the name relapsing remitting. So part of the remission part is as the inflammation kind of can naturally die down. There can be or it's unclear. We're working on remyelination therapies, medicines that can truly repair the myelin, but there's still neuroplasticity that can happen. And so it's really common, especially early on, for people to recover from their relapses, to improve. So absolutely, there can be improvement. Like that one graph that I showed earlier, that first attack, some as an example, this does not speak to every single person's experience. This is just sort of an amalgamation of lots of people's experiences, but you might recover all the way early on. that's your body, recovering from the inflammation. There's neuroplasticity. You've kind of way I phrase it for patients is your body kind of reroutes traffic around that scar, and so the new connections get made. But that's harder and harder and harder to do the more and more lesion, the more scar tissue that accumulates. Basically, it gets harder for your body to recover. Again, why we want to prevent anything else from happening. Yeah.
Has it been tested now on rats or other animals or something that there is showing on a treatment that's going to be soon?
Yes.
5 years for remyelination?
I'd say, yeah, the current remyelin, no, this is, I believe, I think Dr. Smoot talked about a little bit of this in his talk, but the remyelination therapies are still at the level of kind of the mice research, kind of the lab research level. Sadly, nothing that is, the step before an FDA approval is sort of phase 3 clinical trials, as we say. Nothing is at that level yet, unfortunately. So there's a lot of things that are very promising at the sort of the animal mouse model level or in the laboratory that I think, yeah, that is very, very promising. I think we're going to get there. Nothing that is about to be approved, shall we say. So I think hopefully it's just a matter of time. Fingers crossed. But yeah, nothing I can say, oh, this drug is about to be approved. Sadly, nothing like that. So this is essentially showing, again, over time, disability on this axis. And so intervention to diagnose, this is, again, an average. This isn't necessarily what's going to happen to every single person, but you get the idea where if we can intervene early, there's a whole range of outcomes that potentially lower disability associated with that, as opposed to no treatment. There's a greater range of outcomes, including higher disability. I say that there's still a wide range of outcomes. Again, I mentioned before that there is a spectrum of how active MS can be. Some people are severely affected. Some people have, fortunately, very mild, very benign disease. It's hard for us to tell in the very beginning after that first relapse. We have no way of knowing who's going to be who. We don't know who's going to go on to have a more aggressive course and who's going to have a really benign course. But because once disability happens, we can't undo it. That's why kind of our recommendations generally are to start a preventative disease modifying therapy early.
The stem cells, some people have actually got, they're about in a wheelchair and they're out of it with the stem cell, but it's a hospital stay and it's all
absolutely, yeah. There's a lot, and that's one of the things on the horizon. So speaking of phase 3 trials, there is a phase 3 trial going on in the United States for stem cell transplant. OHSU is a site, and they are looking at stem cell. For stem cell transplant therapy. It's 25 sites over the United States. They started the study right at the beginning of COVID, so I don't know how it's going, but I think so. It's in process, and it might be a little while before we see those results. But it's something that they do in Europe, and so we've used that European data as kind of as the basis for developing and designing this. It's called BMS is the study that's going on right now. So I'll get to the therapies, but I view lots of different therapies as all supportive. There isn't any single treatment for MS. It might include disease modifying therapy and diets and exercise and, and lots of different things that are all supportive of the treatment. There's sort of it's a and, not an or, if that makes sense. So this is kind of a timeline of the many different MS medicines that have come out over the years. You can see the earliest ones only came out in the 90s. And then there kind of wasn't a whole lot for a little while until we got to kind of the 2010s. And then in the last couple of years, there's been, and you can kind of just see a lot of different things coming out. And even since the slide was made, this is Briumvi that came out. That's another infusion medicine. It's also probably outside of the scope of the talk to talk about every single. I will not overwhelm you. We're going to do a brief overview, but to go into depth about the side effects and pros and cons of every single medicine is way too much information. So this is the kind of a 10,000 foot view of the options out there. So this is these platform therapies. These are the oldest medicines. These are the ones that have been out since the 90s. They're all injection medicines. There's Copaxone, that's subcutaneous. can be given every day, or there's a 3 times a week injection. There's a generic version of it. And then there's all the interferons. That includes Avonex, Betaseron, Plegridy, Rebif. Some of these are intramuscular, some of them are subcutaneous, and you can see they vary about how often they are given. But I group them all together because they all work in the same basic underlying way. And they more modulate, I would say, your T cells essentially. They're kind of, the T cells are the ones that go attack your brain and your spine. And so, yeah, we consider this class more, not immunosuppressive, but more modulates your functioning of the immune system. While we're talking about injections, there wasn't any new injection medicines for a really long time until Kesimpta. This came out in 2019, I want to say. 2019 or so. It's subcutaneous. It's just once a month, and it works very similar to Ocrevus. I'll talk a little bit about that, but it's possible you've seen any of the many ads on TV for Ocrevus. I'll hold off on talking more about that, but that is the most recent injection therapy that's come out. Then there's pills. That's another way we can get medicine, give the disease-modifying therapies. It's kind of grouped by class of medicine. Again, they each have their own list of risks and side effects and benefits and advantages and disadvantages. Main thing is some are once a day, some are twice a day. And then the kind of unique one is this Mavenclad that's sort of given, you get 2 courses. Each course is about a week long, and it's given, so you do a week of pills, and then a year later, you do another week of pills, So 2 courses of 2 cycles. I know that sounds confusing, but that's kind of a unique option in terms of pills. And then finally, there's the infusion medicines. And so the oldest one we have is Tysabri. It's every 4 weeks. Lemtrada, that is just it's 5 doses altogether at once, and then a year later, you might get another dose. There's some other problems with this, and ask your MS doctor about this medicine. And then I'd say easily the most popular, most common medicine these days is Ocrevus. It is an infusion medicine. It's every 6 months. So it's hard to deny the convenience of that. But just like with all these medicines, there are risks to it too. And so it's not right for every single person. And then Briumvi, it's the same thing as Ocrevus. It's just a shorter infusion time. There's a lot I could say about each of these, but for the sake of time, I will not go into it because I also, something that everyone with MS has either heard about or will probably at some point hear about is this PML issue, PML risk. PML is progressive multifocal leukoencephalopathy, so that's why we just call it PML. There's a virus, the JC virus. John Cunningham is the one who found this virus, and he named it after himself. It's really common, and just over half of the general population has this virus. I could have it. Half of us in this room could have it. By itself, it's just this kind of random cold virus, essentially. I think it's been found even in like the dirt before. It's just around. And so by itself, it's kind of no big deal. But when your immune system is suppressed in a certain way, easiest way I kind of think of it is it basically reactivates and goes crazy and can cause this bad brain infection called PML. And so you have to have this virus in order to get PML. The symptoms of it can come on really slowly, and they can be memory loss, weakness, vision loss, and the thing you might be thinking is, how do I tell that apart from an MS relapse? The MRI can look different, and so that's one way we check. We can do a blood test to look for this JC virus to see if that is something that you have. The reason we care about this is because there's certain MS medicines, Tysabri is frankly the main one, that can increase your risk of this. I should also mention that PML, this is not an MS exclusive problem. This can happen if you have any autoimmune condition. This can happen with a lot of different autoimmune medicines, whether you have a rheumatoid arthritis. This can happen in cancer patients, HIV patients, anything that can suppress the immune system in a certain way. It's not all immune suppressing medicines. So fortunately, PML is extremely, extremely, extremely rare. We want it to stay rare because it can be fatal. And where it isn't fatal, it can leave a lot of bad residual symptoms. So yeah, I mentioned Tysabri is the biggest risk. Before even considering this medicine, we check people for the JC virus, and if it's positive, we won't give you Tysabri. That's how associated it is. So we don't even go there. The other MS medicines have a much lower risk. So yeah, and specifically the risk goes up after 2 years of treatment, but we got too many other options, in my opinion, to mess around with a risking PML. That's just me though. So how do we decide what medicine? Ultimately, I do my best to have a shared decision making with the patient. It might vary on your age, exactly what subtype of MS you are. Admittedly, primary progressive MS. There's only one FDA approved medicine for primary progressive, and that's Ocrevus. So that limits the choices a little bit right there, unfortunately. And we, because of the various risk factors, we might take into account what other medical conditions a patient might have. For Tysabri, we take into account the JC virus, of course. Profession, this might, mean if you travel a lot, it might be hard to take the injections with you. It might be easier to do pills. If you work in some other high risk environment, or you're not able to, say you can't make it to the infusions. Or maybe there's so many different factors, and it's very different from person to person. Yeah, distance from a hospital or infusion center. If you live 6 hours away from the closest infusion center, that might make getting an infusion more difficult. We take into account depression and fatigue. Sometimes certain medicines, and particularly the interferons, could make depression worse. Less so with some of the other MS medicine. So you can kind of see, depending on what else is going on, we might say, all right, that's a good that doesn't sound good. This might work okay. Sadly, insurance coverage has to play a role. We always get an authorization first, so no one gets charged, before we know if it'll be covered or not. But I hate to say it, but sadly, that can play a role in decision making. And then the ultimate is really what the patient wants and a preference. Some people say, you couldn't pay me enough money to inject myself. Other folks really hate taking pills or will never remember pills. And so that is, the best. I tell my patients that the right MS medicine for you, in addition to all these factors, is the one you'll take. If you are not going to, just to be completely honest with yourself, if you're going to forget pills, maybe we do something else. Or if you won't be able to inject yourself, maybe we do something else. Absolutely, you can switch. Yeah, definitely can switch. The things that would prompt me to say, okay, let's switch are if you did have a new relapse, if you had new lesions on the MRI, or if you're having side effects. So that could be really short. If you take a medicine and you are not have bad side effects, you are not tolerating it. I've switched people even after just a couple days, so we don't have to force you to take a medicine for really long if it's just not agreeing with you. We got too many other options out there now. In the 90s, when we really just had those three, it was like, well, okay. But now, again, we got too many other options to go through that. So, and there's, yeah, it's a good question. It depends on what's going on. On average, we end up maybe after, we might get one more frequently in the beginning if you're just newly diagnosed. If we're just getting on a medicine, we need to assess how it's working. After the dust settles, we might end up, I'd say the average is about once a year. Sometimes if there's something in particular we're looking for, we might get it more often than that. But on average, I'd say once a year. Sometimes we'll spread it out depending on how, depends on a lot of different factors, but I'd say it averages out to once a year. And usually more once, like I said, the dust settles after your. Yeah, so it might, for example, if you got an MRI that led to the diagnosis. If say you were trying to get you started on a new medicine, but then you have another attack or new symptoms, I might do another MRI then. So that's why it really depends on how you're doing, how you're feeling. If I will also, once you get started on a medicine, I like to do an MRI rather than waiting a full year. I like to check after just about 6 to 9 months to see if the medicine's working or not, so we can move on to the next one. I don't want to let you be on a medicine if you're not responding to it. So it might be more frequent in the beginning based on if you're having new symptoms, we start you on a medicine, if we need to follow up that medicine. But what if someone is not having new symptoms and you're on a medicine that's working for you, you feel well, that's where we might just check it once a year. So yeah, there's no rule of thumb or like, oh, we have to do it this often. It really is in response to how the patient's doing really, and how, if there's symptoms we need to check out or evaluate, or if there's, there's so many different factors to say the least. But very good question. Any other questions? Okay. What was I going to say? Oh yeah, so talked a lot about medicine, and it's very typical, normal, even for folks to say, I don't know about this. This tends to happen, say if you're feeling okay, say you've recovered entirely from your relapse, folks don't want the treatment to be worse than the disease, and it's hard to argue with that. So that's one reason why some folks might want to hold off at first. The cost, again, sad to say it, I wish it wasn't so. There's a lot of copay assistance programs out there, and we will do our best. We have an excellent team of pharmacy folks, pharmacists who help work with our patients on that. But the sad truth is that can absolutely play into our decision making. Again, fear of needles. This was more of a thing when we only had the injection medicines. Now we've got other options out there that you're not forced to inject yourself if you're deathly afraid of needles. And then, of course, side effects. Again, I know I glossed over it. It's because talking about each individual side effect for each medicine is a whole nother lecture on its own. So yeah, yes, yeah.
There are some medications that the company itself pay for or do
absolutely, yeah,
cost free if you can't afford it.
Absolutely,
it's a prescription assistance program or something.
Yes, a lot of admittedly newer medicines. The drug companies are highly motivated to put you on, to take their medicine. And so they have a lot of copay assistance programs where some people can get free drug. There are some of the older medicines that are generic now. There aren't copay assistance programs for the generic ones, but in theory, again, this does not always work out with each person's insurance, but one would hope that it would be more affordable to get the generics. Again, complicated, and it just depends a lot on each, can vary not only from, can vary a lot between each person's insurance plan, unfortunately. So this is a daily, and I cannot even keep, every year they change every insurance changes their formulary every year. We run an authorization. I've long since given up trying to memorize what insurance covers what. They change their mind too much. So we get an authorization, which basically is us asking the insurance company, hey, you want to pay for that? Hopefully the answer is yes. And that's part of what our fabulous pharmacotherapy team helps with, is if you are on a copay assistance program for any medicine, they help with the logistics of that. And I love them dearly for it. Makes me glad that there are so many options out there. Again, back in the 90s when we just had 3 injection medicines, it's a different ballgame now that we have 16 MS medicine. So again, I will just kind of just very briefly talk about all the wellness. It's very important. So that's why we have a separate talk about this, that our nurse practitioner, Marcia Woodburn. It was earlier in the year. I think this will be a recurring presentation. So just a little bit about this. For more information, look for the next presentation by probably Marcia again. So diet changes. There isn't any single MS diet that's been 100% proven to be better than the rest. There are a lot of different MS diets out there, and all of them, I have patients that it has helped all of them, so I think that the main a common denominator amongst a lot of these diets can be, low fat, less processed foods, more fresh fruits and veggies, maybe low sodium or possibly low fat. High fiber seems to help. There's a few studies that paleo diets could possibly improve energy, but it's hard to do. It's hard to do diet studies, honestly. It just is. Smoking's bad. Smoking is associated with worse MS. Probably could have guessed that. In terms of supplements, a lot of people take multivitamins. It's not required. Many people might get various vitamins in their diet, but if you don't, then a multivitamin is very, very helpful. I talked a bit about vitamin D, alpha lipoic acid. There's some data. My old colleague, Rebecca Spain at OHSU, is actually the one who did the main studies about alpha lipoic acid, helping, especially with slowing down progression for MS. So that is a supplement that I don't think think the study's closed, but she hasn't analyzed all the data yet. So I think there'll be more coming out about alpha lipoic acid. Yeah.
Waste of time, but I've never heard about full pump acid. How do I get that?
It's a supplement that I think would probably be at any kind of natural food store or like.
Does it come on insurance as like vitamin D?
I don't know. That is a good question that I do not know the answer to. Most of my patients who take it just buy it over the counter, admittedly. I don't, it's worth a shot. That's
Yeah,
something.
I know when I see you, but I'm gonna, that.
Yeah, we'll talk about it.
Remember.
Yeah, okay, I will try. Exercise. There are lots of studies that showing regular exercise is associated with or can help with energy levels, but sometimes easier said than done when you have MS and MS symptoms. So we encourage any kind of exercise that you can tolerate is great. And then things like massage and acupuncture can be really, really helpful, especially for various pain and spasticity and energy fatigue. So we absolutely, again, I kind of view the treatment of MS is sort of there's a platform you're trying to support, and all of these are different arms of that kind of arms of support to provide treatment. So we talked about some of these already, but this is just what's on the horizon. I talked about the remyelination agents to be determined. Hopefully something soon. Stem cell transplant for not only resetting the immune system, but even possibly for repair. Probably a little bit closer again. What was I going to say? Yeah, just because that phase 3 study that's happening right now. For biomarkers, neurofilament light chain is a blood marker that has been shown to be associated with relapses. Its problem is it can be elevated with a bunch of other stuff as well. So if this isn't quite available commercially or prime time yet, because if we were to get it and it was elevated, I can't say, oh, that's definitely means you have an MS relapse, because too many other things can cause it to be elevated. So I think it's coming soon, but we've also been hearing it coming soon for about like 5 years now. So we'll see. Treatment for progressive MS severely lacking, and then kind of been alluded to, but yeah, personalized treatment. What is a medicine that you are personally going to respond to? I think that we've got a long ways to come on this, but hopefully we can make progress with this, whether genetic testing or other ways. So it's my last slide, and then I'll get you out. 6:29. Nice. So we are a Center for Comprehensive MS Care and a partner in MS Care. That is sort of a designation from the National MS Society. There's 5 of us physicians and our nurse practitioner, and we have have a research program where we a bunch of different studies are always opening and closing. So I will not talk about exactly what's going on, but on our website would have the most up-to-date research studies right now. There's also at the website our biannual newsletter where all of the current studies are listed. There's also a lot of registries. We encourage the Pacific Northwest MS Registry is something that is open to every person with MS. The only requirement is that you have MS, basically. And that registry is a great, essentially, would let us, we would send a survey about twice a year. Takes 10-15 minutes, and that helps us collect data. And there's been studies our center has done using that registry data already. So yeah. In terms of other resources for information, because again, it's probably has raised more questions than I answered for you. But the MS Association of America and the National MS Society are both great sources of a ton of information that is easy to understand and accurate. So I recommend both of their websites basically for learning more about MS, and for clinical trials happening all over the United States, not just here. Any clinical trial will be registered at clinicaltrials.gov. So our friends in Seattle and at OHSU and around, all over the US, any studies that are happening are registered there. And that is the last slide.